Thank you very much. It's great to be here, and I've been asked to do this over several years and finally was able to coordinate it together with the schedule and actually make it happen, and thanks for the introduction. Talk about a low stress kind of presentation. My boss is here, so that really makes things really nice and mellow. My armpits are kind of dripping already, but I'll try to keep my cool and not panic too much. What I want to try and cover this evening is some of the observations I've made over the years and kind of mistakes that people make in travel that sometimes have some pretty negative consequences. Give you some update information on vaccines and other things to consider when you're traveling to try and stay healthy when you travel, so you're not one of those individuals that we see every couple of years who picks up malaria in Thailand and almost dies at a hospital in Thailand before eventually making it back to Fairbanks. Or one of those people who comes back home with an illness and doesn't think about talking to their healthcare provider of, oh, by the way, 3 months ago I was in Bangladesh, and if I've got a fever, maybe I need to think about malaria, not just the flu. An interesting story that came out of colleagues in Canada. Jay Keystone is a family medicine provider in Toronto, and he presented at a lecture in Seattle several years ago, and his comment with malaria in Canada, the average Canadian had to see 3 healthcare providers before they died from malaria. And part of that was not that they had bad medicine in Canada. I think they have good medicine in Canada. A lot of times the travelers didn't think about what they did 3 to 6 months ago, and a lot of times the provider didn't ask, by the way, where have you been in the world? And people would come in with flu-like symptoms, which as the symptoms of malaria are headache, muscle aches, joint aches, and high fever. And if it's the flu season, it kind of gets passed off with the flu until you don't get better. You go back again, then you don't go back again because you die from it. So one really important take-home point for people that do health care as well as travelers is if you go see somebody post-travel, it is really worth your while to volunteer the information. Oh, by the way, I just did a safari in South Africa and Mozambique and Zimbabwe, or oh, by the way, I was in Myanmar or Burma for 2 months. And kind of keep that in mind when sorting out the rash, the fever, what else is going on, because the differential diagnosis of fever and return travel is malaria, malaria, malaria if they've been to a malaria endemic area until proven otherwise. So that's really useful information for healthcare providers to think about, and I think my colleagues at Tanna Valley and other folks I've talked to in town are pretty good about that. But you as the patient who may be going afterwards, that is a really good thing to volunteer, because sometimes hoofbeats in Alaska are caribou, but sometimes they're actually zebras from Africa also. So I want to talk a little bit about morbidity and mortality with travel, why people die when they travel. I want to talk about vaccines and some more common problems, like one of my favorite topics is travel diarrhea. And if you're really into travel diarrhea, there's a 260-page book, Travel Diarrhea, put together by Stefan about 5 years ago that really goes into all the nitty-gritty details about travel diarrhea, if you're that enthralled with it like I have been in the past. So the primary reason people die when they travel is the same reason they die when they're at home. 50% of people who die when traveling die of cardiovascular disease, heart attacks and strokes. So I think it's really important with people that have risk factors or underlying cardiovascular disease to really make sure the disease is well controlled before traveling. And looking at the stressfulness of a trip, I see people all the time who go to South America, they're going to do Machu Picchu, they get into a high elevation and acclimatize for 1 day, 2 days, and they're running up above 7,000, 12,000 feet, where there's a lot less oxygen, and have their heart attack up at Machu Picchu. And you can't call 911 really easily from isolated places in the world like that. So it really behooves people who have chronic medical conditions to make sure those medical conditions are stable. And if you're talking to your regular healthcare provider or you see somebody that specializes in travel medicine, it's important to talk about what those risks are and how to minimize those risks. Altitude sickness, just to differ a little bit, everybody thinks about taking a pill called acetazolamide or Diamox, which can help you acclimatize a little bit more quickly. But I think the more appropriate way to acclimatize is plan ahead. And if you're going someplace where you're at high elevation, because most of us here live between 600 and 800 feet, and if you're going someplace in Nepal or South America, you may be starting out your trip at 7,000 to 10,000 feet. And I was reminded of this myself after doing a bicycle trip in Indonesia several years ago. I went to a travel medicine conference in Santa Fe, and I'd been bicycling for a month, so I was really in great shape. So I get there and it's warm, and I go out for a run, and I wonder why my heart's like pounding out of my chest and I'm really short of breath. And then I realize, oh, Santa Fe's like 7,000 feet, and I'm not acclimatized. So it's important to keep in mind, trying to set up a trip so that you have time to acclimatize, take some of the stress out of travel by setting up itineraries where you have layover days coming and going, just to reduce that stress, and especially if you got chronic medical problems that don't do well with stress. Also medications, I see people make this mistake all the time. They put their pills in their check bag, and their check bag doesn't get where they're at. Or their check bag gets there, but the pills are gone. And if you leave your pills in their original prescription container, and you don't put 3 different types of pills in one container, do not do that. If you leave your pills in your original container, most people at security will not hassle with your pills. If you've got needles and syringes, sometimes it's nice to have a letter to go with you saying this person has needles and syringes for their personal use and kind of medical concerns, because sometimes those are a little bit of a hassle going through security because of the sharps type thing. But it's really important that all your medicines that you take on a regular basis, you take enough for that trip. And I tell people to, if they're not taking their whole bottles, at least a 2-week buffer, because you never know when you're going to get delayed or what happens in your itinerary that keeps you from getting back home. But definitely don't put your medications in check bags, and put your medications in hand carry-on bags for your chronic medical concerns. So for those 50% of people who don't die from cardiac and vascular disease, 25% of people actually die from motor vehicle accidents. And if you look at statistics for Africa, Asia, Southeast Asia, Russia, Central America, South America, it is outrageously high motor vehicle accidents. And I'll try to keep science in here, but sometimes I get a little anecdotal. How many people have gone on a trip where several times throughout the trip thought, I'm going to die? Raise your hand. Okay. India, I'm going to die. Egypt, I'm going to die. Turkey, for sure I'm going to die. So that's unfortunately why people die when they travel. I'm kind of guilty about pushing it a little bit, like riding through the Jordanian desert to go to a camp in the back of a pickup truck, something I had done since I was a kid in Iowa. And I know what happens to pickup trucks when they launch over the cliff and fall and crumble and people get like a die kind of thing. So I thought periodically I'm going to die. Also in camp periodically I thought I was going to die also because the camels were kind of wild there. But motor vehicle accidents are the primary reason people die while they travel. So I go out of my way to find functional seat belts, something you and I kind of take for granted in this country, but traveling in Nepal in the 1980s, I was really surprised with how many vehicles did not have seat belts. I also discovered riding in the bus is better than riding on top of the bus because people fall off the top of the bus and get run over by the vehicles behind them. Same thing with trains in India. People fall off the top of the train in India and get crushed, by the train behind them. So simple safety stuff, things that you and I would probably not do at home, but something happens when we travel where there's that little bit of an adventure and that little bit of a risk-taking thing. And I encourage people to step back and say, do I really want to jump off this bridge with a bungee cord on my ankles? I've done that also. It was an interesting rush, but I was trying to figure out with the bungee jumping in New Zealand is like, how did they know the cord was good for 460 jumps? And where am I at in the sequence of the jump? So we tend to take risks, but I encourage people to step back a little bit and say, how can I practice safety and not become one of these mortalities of 25% of people who die when they travel, if they do die. The other thing is, this is a little anecdotal also in China. How many people have been to China? I think they drive like we play hockey. My greatest risk and concern in traveling in China wasn't motor vehicles as much as it was bicycles. And trying to get across the street in Beijing or Shanghai where there's just bicycles everywhere. So something that I discovered I'll share with you, and I encourage you to think about this. Find a little old lady who's from there and go stand next to her. If she's trying to cross the street, take her hand and have her help you get across the street. You're a little bit less likely to die by being run over by bicycles. And what's happening in China now is they got all the electric bikes. So it used to be you could at least hear them kind of coming. But with the electric bikes, there's no noise, and they're like, so safety when traveling, I think, is worth keeping in mind and considering. The other 23% of people who die when they travel, drowns, falls, suicide, homicide. The reality for me in Nepal, doing some support for some mountaineering expeditions is, we're going up these absolutely amazing laid out little footsteps going up cliff sides, and if you turn left, you walk into the hill, and if you turn right, you drop down about 2,000 feet. It's like, whoa. So I learned a long time ago, and something I'll encourage you to think about. When I walk, I walk. When I want to do something else, I stop. And surprising number of people fall because they're multitasking. They're trying to take pictures, they're trying to look at their map. And, if you go to, France, Rome, Egypt, whatever. Yeah, standardization in steps just never existed a long time ago. And I see people all the time who return because they had some major accident, a broken arm or broken leg, just because they were not paying attention to just safety and walking. Also, a fair amount of the world drives on opposite sides of the road from us. And our wonderful friends in England have helped us because, I don't know if you've been to London, if you look down, it says look right instead of looking left. Because most of us look left before we cross the street, right? But in London, driving the opposite side of the road, if you're looking left, you're not seeing the traffic that's coming right at you in the lane there. So I was always impressed the first time I went to London is that they had all that stuff written down on the road to try and keep us from getting run over. So the interesting thing with travel, which actually is where I spend a lot of my time talking to people in travel consults, is infectious disease. The reality is when people die with travel-related experiences, only about 1% to 2% of people actually die from some infectious disease, but we spend a lot of time talking about vaccines and malaria and other stuff, but it's actually a relatively low number of people who actually die from some infectious disease. Probably the most common infectious disease that people die from when traveling and coming back home is malaria, and we'll talk about malaria prevention. But there's a wide variety of other viruses and less so parasites that people will pick up that have a fairly high mortality rate. One example would be yellow fever. We're seeing a lot less yellow fever in the world than we used to, but the mortality rate on yellow fever is still 30%. We don't have any treatment for it, and we have a vaccine for it, and I'll talk about some of the issues with the vaccine that have come about in the last year. So I'd like to talk a little bit because infectious disease, a lot of the infections that we do see are insect-borne, mosquito-borne, tick-borne, fly-borne, is basic insect precautions. And we basically have a couple things that we can do. There's barriers, and those would be things like doors, windows, screens, and bed netting. And actually, malaria prevention programs in Africa basically are bed netting treated with permethrin, which is an insecticide that's a neurotoxic insecticide to insects. And if you just drape that over a crib for a kid less than 5, and if you can get a kid in Africa to survive their first 5 years and not die from malaria, they're more likely to survive when they do get malaria later on. So simple things like doors, windows, screens, bed netting, and if it's treated with permethrin, make a big difference. Also, other barrier protections would be clothing, microphone. And you can buy the ex officio clothing. I don't know if you've seen it in the sporting goods stores. It's the insecticidal clothing. You buy it, you put it on, and it's supposed to protect you against insects. And it's actually just cloth treated with permethrin. And nowadays you can buy the permethrin in spray bottles, and you can treat your regular clothing. I don't know about you guys, but mosquitoes always bite me through my t-shirts. The little gnats and fleas always get under my socks, so I'm going like this all the time. So if you just treat your clothing with permethrin, and that actually works for Alaska also. I used to do a fair amount of camping. I always treated the net on my tent with permethrin, and I'd wake up in the morning, and it's not a real Buddhist thing, but it was amazing the number of mosquitoes that would be dead right out the front of the net. I was traveling in Ecuador for a number of years ago and stayed in a jungle lodge, and our bed netting was treated with permethrin, so it was always an interesting stuff in entomology to wake up in the morning and sweep up the line of insects around the bed that died during the night that thankfully didn't chew on me because I was underneath the bed netting. Also, if you're a good Alaskan, you have to have your favorite bug dope. And there's some interesting things with bug dope. And there's some really good stuff, and there's some stuff that probably doesn't do a whole bunch. And probably we're in the best test ground that there is for bug dope, because we have our mosquitoes, and they vary throughout the season. And probably DEET is probably one of the best products that's out there. It's been around for a long time. It's got its pluses and its minuses. How many people remember REI Jungle Juice? It was like 98.9% DEET. And you can't find it much anymore. And the interesting thing with the higher concentrated DEET products is you basically just had to put them on less frequently. So most DEET products nowadays are somewhere between 20 and 50%. And a 20 and 50% DEET product will probably last most people about 3 or 4 hours. The cool thing that's happened with DEET in the last few years is there's some DEET polymers out there. So they combine the DEET with a polymer, and when you put it on your skin, one less is absorbed through our skin, so our lips don't go as numb. And it actually lasts longer on our skin, and it doesn't sweat off quite as easily. So one of the products that's out there is Ultra Thaw, and it's a 3M product. They don't tell me that to sell the product, but it's probably one of the better products out there. You can find it at REI, Goldstream Sport, Beaver Sport, most of the sporting goods stores, and it's a cream instead of liquid that leaks out of the bottle and melts all the plastic that we have. So Ultrathon, a DEET product, is a cream, and it's a DEET polymer, and actually it lasts about 10 to 12 hours. And I spend a lot of time outside in the summer gardening and outdoor stuff, and I can put it on a Saturday, and it's usually about 10 hours later I think about reapplying it again. I'll still use the other products or 20, 30% if I'm only gonna be out a couple, 3 hours. And also there's a bit of a misconception with DEET in that, people die from DEET, and there have been 3 documented deaths of infants who had DEET applied, but the kids were literally dunked in the product almost. It was totally applied inappropriately. It's a neurotoxic compound, so it can get absorbed through the skin. So if you're an infant and you've got a great surface area and that little brain in there, it does have that toxicity. So it's important with whatever insect repellent that you're using to make sure you read the directions on it. One thing I learned a long time ago is how much DEET is absorbed through our mucous membrane. So I learned to wash my hands after I put on my DEET and was careful where I put my fingers. And also if I use the spray products, I usually spray them on hand and apply it by hand on as minimal area as possible. So if you got your permethrium clothing on and your DEET on your skin, you're doing a lot to minimize mosquito bites, sandfly bites, horsefly bites, tick bites, et cetera. It goes on and on. The other product that's relatively new for us, but it's been in Canada and Europe for quite a while, is Precautions. It's actually a plant-derived product, and it's probably equally effective to DEET. It's about a 10 to 20% product. It lasts about 3 or 4 hours. So for people that are averse to DEET for whatever reason, Precautions is another good example out there. Human lemon eucalyptus is pretty commonly used in Asia, Southeast Asia, Indonesia. The downside to lemon eucalyptus and the citronella-containing compounds is people tend to develop a hypersensitivity to them. So it's easy, if you use it for a while, to actually get sensitive to it and actually get a rash from it, but they can be fairly effective. Bio-UD is a tomato-derived insect repellent that works fairly well. Skin So Soft, it's been around for a long time, Avon product. The joke in the travel medical community is probably the most effective thing about Skin So Soft. It's kind of oily and the insects stick to it and drown in it. As far as working as a repellent, maybe it works for about 20 minutes, but it's not one of those, if you're traveling in the tropics, that will give you a whole lot of protection from insects who spread some of the bad diseases. Other things that are out there that really haven't been proven to be very effective, the citronella compounds, the oral compounds, people swear garlic, B12, et cetera, the electronic transmitter type things. If you look at some really good studies where people were wearing those, and then, I don't know where you get these volunteers, you walk into a chamber with about 1,000 mosquitoes, and they videotape you, with your skin exposed, and they see how many bugs are landing on you. Those just didn't prove to be very effective. I remember seeing some of the early research that was done with DEET, where they had a cage of mosquitoes, about 1,000 mosquitoes in a cage, would apply the DEET to the arm, and a guy would stick his arm in there, hold it for 10 minutes, and lo and behold, would not get any bites. So the important thing also with insect repellents is try it at home, make sure it's gonna work for you, make sure that you don't have any toxicity-related issues with it. But if you just minimize insect bites, you reduce your risk of malaria. And reducing the risk of mosquito bites with malaria is probably as important as taking a pill. There's also Zika virus, there's chikungunya fever, there's leishmaniasis, there's, the list goes on of all those insect-borne diseases that we don't have vaccines for. So insect precautions really are kind of paramount if you're trying to stay healthy when you travel. I'd like to shift a little bit to vaccines. And one of the great things actually about being in Alaska, and especially dealing with young Alaska travelers, we have a very well vaccinated population in Alaska. We've got a good state vaccine program. The school nurses are really good about chasing people down the hallways and tackling them if they're not up to date on their vaccines. The other nice thing about that is when I see somebody that's been in the Alaska school system since the 1980s, I can usually get a very detailed record of the vaccines. When I'm dealing with older travelers, me included, it's hard to keep track of all the vaccines that people have. So when I see somebody for a travel consult and I'm talking vaccines, it is really nice to have documented information on what vaccines they've had, when their last boosters are. So now you can get vaccines from us, you can get vaccines from public health, you can go to the pharmacy and get your flu shot and pneumonia shot, you can get your shingles shot at the pharmacy. Just for information sake, Tanana Valley is not the only show in town for doing travel vaccines. You can actually go to the pharmacies, and some of the pharmacists have standing protocols where they can talk to you about hepatitis A, hepatitis B, typhoid vaccine, et cetera. And because they operate under a protocol, some of those vaccines you can actually get by doing a consult with a pharmacist and get at the pharmacy. And there's some pitfalls in that you need a little caution about that I'll talk about. But people should have some kind of record for a vaccine. This is my WHO vaccine record. And every time I go anywhere into the clinic for my flu shot every year, my yellow fever vaccine, it gets put in this record. So I have a fairly complete record of all the vaccines that I've had over the years. And if I see something like this and somebody coming in for a travel, I am elated. It's like, oh, well, this is so wonderful. Because then I'm not second guessing what they had and what they haven't had. You know, if you spend time in the military, and I know the years you're in the military, you can have a pretty good idea what vaccines you have based on the years you were in and when you came out of the military. But it's really nice to have documented sources of vaccines. So when you go to your pharmacist for any vaccine, ask for a vaccine card. We see your regular healthcare provider, take that card in so it can be put in your charts so that when somebody's talking to you about the vaccines, routine vaccines and travel vaccines, they have a really good record of that. So this is a really great thing to have. I also keep it with my passport, and that way I always know where it is. You know, that lost piece of paper is like, yeah, I've got one, but I don't know where it's at. But if I keep it with my passport and I always know where my passport is, I've always got my vaccine record. So try to get documentation of any vaccines you've had in the past if you're going to talk to somebody about travel-related vaccines. So routine vaccines to keep in mind: tetanus, diphtheria, and pertussis. Every adult at some point in their life should have a booster on the pertussis vaccine. Our Australian counterparts about 5 years ago taught us that if you don't keep Australians up to date on their pertussis vaccine, they had like 50,000 cases of whooping cough in people over 55. And that's a lot of whooping cough. And most people in this day and age don't die from whooping cough, but they kind of wish they would sometimes. Because the other term for whooping cough in the old days was the 100-day cough. It would go on for like 3 months, and it wasn't a subtle kind of cough. So every adult should be up to date on their Tdap vaccine. I have colleagues every once in a while when we talk about vaccines, it's like, oh, we don't see tetanus in Alaska. We do have the bacteria in Alaska that spreads tetanus, and actually about 3 years ago, there were 2 cases of tetanus in folks down in Anchorage. One guy was a non-vaccinated individual that had come into the country with no history of vaccines at all. And the other guy was a guy that stepped on a fish hook and wasn't up to date on his vaccines and decided not to seek any health care. So even in Alaska, we can see tetanus, but especially if you're traveling in the tropics and you step on a rusty nail. That's the typical kind of tetanus. Mumps, measles, rubella. There's some young people here, a couple young people. Most of us who were born before 1957 probably had mumps, measles, rubella as a kid. Matter of fact, 97% of folks before 1957 had measles. And so typically I don't focus on that with my older population. And if there's some question about it, we can actually draw blood and do an antibody titer to take the guesswork out of it. But people born after 1957 start getting the MMR vaccine. So we don't see mumps, measles, rubella in this country, especially we don't see measles too often, but occasionally we do. And most of the measles that we see in this country when it starts a small outbreak came from some place where people were traveling to, or they were a traveler returning there and pick it up from family and bring it back home again. Just statistics on measles, worldwide statistics, in 1980, there were 2.6 million people who actually died from measles, complications of measles. And that was in 1980 worldwide. In 1990, with more aggressive measles vaccine programs, that number dropped to 500,000. And in 2014, there were 73,000 deaths from measles around the world. So it really does speak to the effectiveness of a vaccine if it's available and people stick to a plan. Just to remind you, if people who died from measles, I mean, most of us get it. We get the kind of funky rash, our eyes get red, our fever, kind of miserable. But measles actually would cause a pneumonia, and people would die from the complications of pneumonia, or they would get an encephalitis. They would get an infection around their brain and die from complications of the measles infection around the brain. So it's not a benign disease, even though most of us kind of skittered through it if we're born before 57. Influenza, keeping in mind, influenza we always thought of as a seasonal disease, but we see influenza in the middle of the summertime. In the equatorial part of the world, influenza is a year-round disease, not just a winter disease. In the southern hemisphere, our summer, their winter, it's their winter influenza disease. The hassle with influenza is we don't always have all the viruses in the strain, but I think there's more benefit than there is at risk. And we definitely see higher rates of influenza in travelers because you're going through the airport, you're on airplanes, people cough and sneeze and drool on you. I guarantee you they do not wash down the tray table and the armrest in front of you. So it's a place that people pick up a lot of viral infections like influenza. So it's worthwhile doing the vaccine, or at least thinking about, if I happen to get influenza and I'm not doing the vaccine, do I want to take some medicine along? So if it's classic influenza, potentially I can treat myself. Hepatitis A and hepatitis B, the interesting thing with hepatitis A is actually, it's a kid vaccine in Alaska, because actually back in the 1980s when I first came here and was working in Tok, I was actually surprised the number of active hepatitis A cases I would see. And I think the issue with Alaska is we're like the developing world. You never know when the outhouse is going to flood and contaminate the village water supply. And hepatitis A virus you find in stool, and it doesn't die off when you freeze it. And if somebody's throwing their honey bucket out in the village and it's all kind of mucky, so we would see like outbreaks in Tetland or Mentasta or Kotzebue. So actually the hepatitis A vaccine was actually researched in Alaska because we're the developing world and had high incidence of it. It was proven to be a very effective vaccine. So it's been a kid vaccine in Alaska since the 1980s. So that population of people, they typically have had their hepatitis A, they've had their hepatitis B. Hepatitis A, just to go back, that's the one you get from food and water. It's fecal contamination of the world we live in. Hepatitis B is the one you get from blood and body secretion. So with kids, you never know when they're going to drool on each other, bite each other. And hepatitis B is sexually transmitted. They have sex from time to time also. So we saw a lot of hepatitis B here. So that's been a kid vaccine in Alaska for quite a while. You can get separate hepatitis A vaccines and separate hepatitis B vaccines. I talked to all of my travelers about A and B if they've never been vaccinated. And A is the one I'm most concerned about, even people who go to Mexico every year, because it's still pretty common in Mexico and Central America. And even if you stay in the 5-star hotel with the 5-star prep kitchen, if the prep cook doesn't have the hand washing routine down, you can come away with hepatitis A. Then you're an interesting public health concern if you come home for Alaska for a little while. There's also a hepatitis A and B vaccine where it's combined, and that's where I've seen people kind of run into a little bit of trouble, just like seeing a pharmacist, because if you're going to do the combination hepatitis A-B vaccine series, it's a shot now, a shot in a month, and 6 months. So it really takes 6 months to get all 3 doses in to have protection from it. So if somebody gets their first 2 shots, they really aren't protected fully for the hepatitis A part of the vaccine. So there are accelerated series for some of the vaccines. So somebody who is leaving in 6 weeks and they're really going to be at risk for hepatitis A and they want to cover themselves for B, you can do a shot now, a shot in a week, and a shot in a month, and then do a 4th shot a year down the line and still have protection for that short-term upcoming trip. So it's important to keep in mind if you're seeing your regular healthcare provider or you're seeing a pharmacist for vaccine, really ask, will I be fully protected with this vaccine series if I'm doing it before I leave? And if I do the routine series and that won't protect me, is there an accelerated series for the vaccine? Because there are several vaccines that there are accelerated series for. Polio is still alive and well in parts of the world, Pakistan, Afghanistan, Nigeria, and Laos. In 2017, there were actually just 5 cases of polio in the world. So it's one of those immunizations that's probably going to have a big impact on the world population overall if everything continues on. Varicella chickenpox vaccine is out there. A lot of kids get the meningococcal meningitis vaccine now because you never know when they're going to drool on each other and cough on each other and somebody's going to get really sick. Human papillomavirus is a vaccine to try and reduce the risk of that wart virus on the cervix, or reduce the risk of cervical cancer. And then shingles vaccine. Probably a fair number of folks have had the one shingles vaccine from several years ago, and there's a new vaccine out now. If you've had the old vaccine, you can still get the new vaccine. And the new vaccine is 2 shots spread out by 2 to 6 months. The old vaccine worked pretty darn well, but it didn't work quite as well as the new vaccine. So if you've had the one vaccine in the past, talk to your pharmacist or healthcare provider and think about the new shingles vaccine. So required vaccines, there aren't very many required vaccines of travel, and that's a bit of a misconception out there. The one required vaccine, which is actually established by the World Health Organization, is yellow fever vaccine. And it's based on countries that you travel to and other countries that don't want to see you bringing in yellow fever. So South Africa is an interesting place. There's no yellow fever in South Africa, but they don't want to see imported cases of yellow fever in South Africa. So if you go to the Congo and Kenya and Tanzania and Mozambique and Zimbabwe, back to the Congo, and eventually go to South Africa is going to require you to have the yellow fever vaccine because you've traveled through countries who at least have an epidemiologic history of having yellow fever in it. And that's where this card comes in handy, because there's a specific place in there, if you get the yellow fever vaccine, that has to be stamped and signed and initialed and all that stuff. And if you're going through customs and they want proof of a vaccine, and it's usually yellow fever, this is what they're looking for. The new information on yellow fever used to be we did it every 10 years. If you've had one yellow fever vaccine in your lifetime, you don't need any more. So it's a lifetime vaccine. There's epidemiologic evidence, people who even got it back in the 1950s and 60s that still have immunity for it all these years later. So you just need one yellow fever vaccine in your lifetime. And again, that's where that old document comes in handy. If I see somebody that can give me documentation of a yellow fever vaccine, I'm happy to give them a new yellow fever card. The issue with yellow fever is the manufacturing process broke down almost about a year ago, so we haven't had any vaccine in the US for about a year. We were fortunate enough at our clinic to stockpile some, and I think we actually ran out of it about 3 months ago. So the CDC has actually brought in vaccine from France, and there are isolated clinics around the country that you can get the yellow fever vaccine still, but it's the French version of the vaccine, which is perfectly effective, perfectly good, perfectly legitimate. But the yellow fever vaccine for Alaska is in Anchorage. So for people who are planning a trip where yellow fever vaccine may be required, they need to keep in mind that they've got to go someplace like Anchorage, or I've had students who happen to be going through Seattle and they could get it in Seattle, or one young lady was going through Boston, so we connected her with the yellow fever vaccine center in Boston. We probably won't have our yellow fever vaccine again until probably January of 2019. That's at least what we were told a few weeks ago. So yellow fever is one of those vaccines that could be required. It's never required to get back in the US. That's another misconception people have. You know, you can go any place in the world in the US, doesn't care if you come home with yellow fever or not. You know? The other vaccine that can be required is the Meningococcal meningitis vaccine. Meningococcal meningitis is that really bad meningitis that if you've seen it once or twice in your lifetime, you never want to see it again, because from the time you're sick to the time you're dead could be about 3 to 5 days. It's that bad meningitis. We probably see about 2,000 cases a year in this country. Most of the cases come from overseas, brought into the country. There have been cases like in dorms in college where somebody's traveling in Africa, they come back, they weren't sick when they got back, they started getting sick, they cough and sneeze on, drool on their college, dorm mates, and then people come down with meningococcal meningitis. So the one place it's required, if you ever do a religious pilgrimage to Mecca during the Hajj, is actually required to get into Mecca. So for your pilgrimage to Hajj, you got to have your meningitis vaccine. And the reason that is, there's so many people that come from all over Africa to go to Mecca for the Hajj that they've had major epidemics of this meningitis there. Occasionally, so when you're planning a trip, it's nice to go online and look at visa requirements for the countries you're going to. Like just recently, Paraguay's required everybody to have the MMR vaccine. Nobody's really sure where that's coming from. Maybe they're trying to reduce the number of cases of measles that are coming into the country, but suddenly it's a requirement that people have to have proof of the vaccine or have proof of immunity by doing a blood test to make sure they're immune. Polio, for a while, Pakistan, Afghanistan, Nigeria, and Laos were requiring proof of the polio vaccine to go there. So individual countries can have requirements that are outside of the WHO requirements. So it's always nice to check when you're traveling and looking at visa information if there's some surprising vaccine that comes up. So the pitfalls for vaccines, people don't have past records, so sometimes we just got to have proof of the vaccine, so we start vaccinating folks. I do see people who have never had vaccines, and suddenly they're going to go off to a mission trip in Africa. There are accelerated series to bring young people up to date who have never had the tetanus series, never had the measles series, never had the polio series. So even adults can be brought up to date on the routine vaccines and the special vaccines for travel. Yellow fever issue with availability we talked about. The other pitfall I see with people doing trips through large trip organizers or whatnot. Some trip organizers kind of send out a blank statement and think of these 20 vaccines. And sometimes the vaccines they put on their list that you need to think about aren't even endemic in the country they're traveling to. So when people get information, it's at least worthwhile going to the CDC webpage, the WHO webpage. Mike may not like this, but you can call me. Phone call is free. I'm happy to talk to people on the phone, and right now we're not charging for phone calls. And if somebody needs to think about a vaccine, then I'll say, okay, these are your options for thinking about and doing that vaccine. But it's worthwhile planning far enough in advance, so if you need the vaccines, you've got time to do it. And then again, always check with the individual countries' visa information, because sometimes they go outside WHO kind of guidelines. How are we doing on time? Doing okay? So vaccines, that's kind of the gamut of it. Japanese encephalitis, I guess I didn't talk about that one. It is really rare for me to give somebody Japanese encephalitis. Japanese encephalitis is a virus spread by mosquitoes, same thing, insect precautions. You really have to kind of off the beaten path to get Japanese encephalitis. And I'll pick on my pharmacy friends a little bit. They're like, yeah, we can give you the Japanese encephalitis vaccine because it's endemic in the country you're going to. And yes, you do find it in Thailand, but if you're just going to stay in a hotel in Bangkok, your risk of getting it is 0 and your risk of dying from the vaccine is 1 in 20,000. So I always look at the risk of the vaccine versus the risk of disease. If I'm dealing with a biologist who's going to go over and study avian influenza in birds in China or in Thailand where you find a lot of Japanese encephalitis, I'll probably offer them the vaccine. So just because the disease is there doesn't mean everybody needs the vaccine. It really depends on their itinerary, how long they're there. Are they going to be in an environment where they can't always protect themselves against biting insects? Or it's more in that population that they're going to. So we'll talk about malaria if you don't mind now. So there are several different species of malaria, and falciparum malaria is the one that gets a lot of press because that's the one that kills about 500,000 to 1 million people around the world each year. And at least every year or two we see somebody who travels. More often than not, it's a naive traveler. They don't seek out any healthcare advice. They travel, they have a great time, and then they get really sick where they're traveling to. So malaria typically causes real bad flu symptoms. And the pathology with falciparum malaria is when you get bit by the mosquito, the parasite goes to your liver, hangs out in your liver for X number of days, breaks out of the liver cells, go to your red cells, hangs out in your red cells for X number of days, ruptures the red cells, goes back to your liver. And so if you hear the old guys talking about malaria from World War II, they would get these cyclic fevers. And then they'd be kind of, afebrile for a while, and then you get another cyclic fever as it broke out of the red cells and the liver phase. Well, it makes the cells really sticky, so it starts plugging up organs. And most people who die from malaria die from what's called cerebral malaria, where they basically get all these little microclots in their brain. Their brain swells, they go into a coma, and they don't wake up again. I was in Myanmar a few years ago, and Myanmar is the one place in the world you don't want to get malaria because it's multi-drug resistant. And I got a kick out of our guide. He kept kind of trying to downplay the malaria thing, even though I think most everybody on the trip was on anti-malaria medicine. But he would always describe these illnesses where people would go into a coma and they would kind of wake up again, like their evil humors went away. And he was describing cerebral malaria, like yikes. And then I've got several pictures, and I apologize, I don't have slides. I'm a low-tech kind of guy. I have pictures of these water containers in front of like restaurants where they have nice plants and whatnot. And there would be thousands of mosquito larvae in these containers right outside the restaurant. I had on my DEET, I treated my clothes with Prometrium, and I was taking my anti-malaria drug. And knock on wood, I didn't come home with malaria. So minimizing bug bites is the first line of defense to reduce your risk of getting malaria. There's actually about 100 countries in the 206 countries in the world where you actually do find malaria. It's tropical, it's subtropical. If you go above 7,000 feet, you don't find it. So people who just do Machu Picchu and don't go into the lower Amazon basin in Peru, they're not going to see malaria. So I really look at people's itinerary closely, because if you just kind of look at the country, you'll see you got malaria. But if you sit down, and there's actually some pretty detailed maps in the world now that WHO's put together where you actually do run into malaria. If you go to Costa Rica, where there's like 4 cases per 1,000 inhabitants, sometimes all you need is just your personal protective measure and berry protection. Not everybody needs to take an anti-malaria pill. But if you go to the Solomon Islands, or better yet, if you want to get malaria, go to Papua New Guinea, where there's 600 cases per 1,000 inhabitants. I would probably be a little bit more proactive in taking something to reduce my risk of malaria. If you've been around long enough, you've heard about Fansidar and chloroquine. Fansidar is pretty much resistant, and it's a useless anti-malaria drug. Chloroquine, there are a few countries in Central America that chloroquine still works for, but most of the malaria in the rest of the world is resistant to chloroquine. So that kind of leaves us, if you're going to take medication to reduce your risk of getting a malaria, Lariam, which is mefloquine, which we don't use a whole lot anymore, and I'll explain why, doxycycline, and Malarone. The issue with mefloquine is good anti-malaria medicine, but it had a lot of neurological side effects. And what we were seeing in about 12% of the population taking mefloquine or Lariam, they actually would have psychotic episodes when they traveled or get profoundly depressed. And if you're a young guy traveling in Bangladesh, a psychotic episode probably wouldn't work real well. So because of that low, it was 12% of the population, it just kind of fell out of favor, even though it was a good medicine. Doxycycline is a form of tetracycline. It works for malaria prevention also. And then Malarone is the other drug that we have there. The important thing that people get caught off guard with their anti-malaria medicine, most of them you start a day or two before you leave. You take it while you're there, but it's really important that you take it for a period of time after you leave the country. Because if you take it just to the day you left, you didn't finish off the life cycle of the parasite. So we'll see people who came home, they took their doxycycline, they go, I didn't see any mosquitoes, and they stop it. And what they did, if they got malaria, they suppressed the infection, and then maybe 3 months later, came down with malaria because they suppressed it, and it took a while to kind of ramp up again. That's why I tell people for that first year after you're back traveling, really do volunteer that information, because sometimes we see malaria weeks and months after somebody traveled, and they're not even making the association with the fever, and I feel crummy based on what their trip was. So the difference between Malarone and doxycycline has a short half-life, so you have to take it for a month after you return from your trip. Malarone you just have to take for 7 days after you return from your trip. Our Swiss colleagues did some really great studies looking at malaria prophylaxis, and the Swiss are pretty compulsive people. And there was only about 12% of the population that actually took their doxycycline for the 4 weeks after they came back. So that means 88% of the population really wasn't protecting themselves against the parasite. So they pretty much have shifted back to Malarone as their preferred drug, or really emphasize the importance if people want to do the less expensive doxycycline to make sure they take it for that whole month afterwards. I'm going to wrap up with travel diarrhea. So I got a lot of travelers here. How many people in their travels have experienced a bout of diarrhea while traveling? So statistically, on a 2-week trip to the developing world where food and water sanitation aren't what you hope they would be, about 50% of people eat some interesting bacteria that causes diarrhea. The bacterial pathogens, E. coli, Salmonella, Shigella, Campylobacter, the list goes on and on. Most of them, it's actually a self-limiting illness. And self-limiting is, I think, really loosely defined. Most of the time, if you get diarrhea, it will last for like 3 to 5 days. But we've all had, probably to some degree, that bout of diarrhea that we're just like, it's just not kind of going away. So most of the time when you're traveling, it actually is a bacteria. Occasionally it's a virus, just like we get viral diarrhea in this country. Rarely is it actually a parasite. There's a big parasite phobia because you never want to pass a worm out your backside sitting on the toilet. So people always think about that, but parasites are not a common reason for acute diarrhea when traveling. So for years we talked to people about safe food, safe water, boil it, peel it, wash it, cook it yourself. And actually in some pretty good studies done with medical students, they're an interesting study group, and really looking at people that were absolutely stringent with doing all the right things. That was half the population that was studied, and this was a study done in Mexico. And the other half is like, whatever, go for it, eat the street food, eat the worm in the tequila, do whatever you want. And actually there wasn't a big difference between the two groups in a 2-week travel. And I think what that emphasized, and then they tried to piece this together later on, it's amazing how much bacteria we bring to our own mouth. So I really, as much as emphasize safe food, safe water, is washing our hands a lot. In the 80s, I traveled with groups to Nepal and Bhutan, and I was responsible for the healthcare, and especially in Bhutan, we're a little bit isolated, and I got really obsessive compulsive about safe food, safe water. So we actually boiled all of our eating utensils. We boiled our dishes. Our dining space always had soap and water available. We filtered the water, then we chemically treated the water. And knock on wood, for a 3-week trip, nobody got sick. It was absolutely amazing. And especially in one of the towns we were hanging out, and I was talking to a Swiss doc there, they were actually having a cholera outbreak. That made us kind of excited. But if you are smart about what you eat and drink, and you treat your water, and there's lots of different ways you can treat that now. We try to still do that, but probably the hand washing is important as anything. And if you've seen me in clinic talking about travel-related consult, my usual line is, I hope for the best and plan for the worst. I hope you don't get sick. You're that 50% of the population that was lucky enough not to pick up a bacteria. But I always plan for the worst. So my travel diarrhea treatment kit is a roll of toilet paper in a Ziploc bag. I never go anywhere without it because you never know when it's going to hit. And in one end of the tube, I put my Imodium. Imodium is an anti-diarrhea medicine. It slows down intestinal motility. So if you got really bad diarrhea, it's one way to slow it down. And in the other end of the tube is an antibiotic. If somebody's got really mild symptoms, sometimes the Imodium is all they need if it's going to interfere with their trip. And I always tell people they can stay close to the bathroom, hang out there, see what happens. But most people, if they're traveling someplace, they don't want to miss out on things. So most people are a little bit more prone to consider treating with something. So sometimes it's just Imodium is all you need just to slow down stools. If somebody has really impressive watery diarrhea, a lot of times I recommend they consider adding an antibiotic to it. In the 80s, we used a sulfa-based antibiotic, Septra, and it was a pretty good choice back then, but there was a lot of bacterial resistance that's evolved. We use the quinolones quite a bit, that's like Cipro and Floxin, and over the last couple of years, there's a lot more resistance to those antibiotics. So nowadays, the antibiotic of choice is azithromycin, which is a macrolide or erythromycin-like antibiotic. And also what we've learned is you don't need to take it for 3 days, 5 days, 10 days, 14 days. The current recommendation for people who are treating themselves with travel diarrhea is they take 250 milligram pills of azithromycin, 1 dose, and that's it, with their Imodium to slow down the stools. That's it, and then reevaluate the next day. And about 75% of people, that's all they need to do. What I tell people, if they can't fart with confidence yet, they take their other antibiotic the next day, and if on the 3rd day they still can't fart with confidence, then they take their antibiotic the other day. You know what I'm talking about. You're over the diarrhea when you can fart with confidence again. So anyway, you don't have to take it for long periods of time. It's shorter duration, try to knock the bacteria down and see if you bounce back a little bit more quickly. And that's some pretty good studies, again, done in medical students. The azithromycin and the Imodium, 85% of the time, within hours, people were feeling better. They could continue on with their regular itinerary and not have to disrupt their trip. So the caveat for travel diarrhea, when you shouldn't treat, if you have a really high fever and you've got blood in your stools. Those are usually more invasive organisms and you need to see somebody. I also don't send people along with a lot of anti-parasitic kind of medication because usually parasites don't cause acute diarrhea. How many people had Giardia in this room? Okay, so yeah, you can get diarrhea with it, but not everybody with Giardia actually gets diarrhea. Some people just get the gassy, crampy pain. And to really sort out, is it bacterial or parasite, you really got to look at a stool sample. Otherwise, the symptoms from bacterial diarrhea and some of the Giardia type parasites, they're exactly the same. And it's more likely a bacteria, so I tend to err on the side of the antibiotic. That being said, occasionally I send people on long trips along with some tinidazole, which is the anti-parasitic drug that we use nowadays for Giardia. But if they have the opportunity to see a healthcare provider, I encourage them to think about that. So wrap-up comment is something to think about when people are traveling and you get sick during travel. I see people really uptight about seeing people in countries that they're traveling to. You actually can get amazing healthcare almost every place in the world. Sometimes you got to go out of your way to find it. And there are some places that you probably need to go to another country to get more definitive kind of healthcare. But don't be afraid to seek out healthcare. Our Canadian counterparts actually have an organization called IMAT. It's International Association for Medical Assistance to Travelers. You can look them up online and you can give them a donation and you can get a list of clinics that they set up around the world. So what they do is they try to go into local communities and support the healthcare system that's there. They try to make sure they're practicing kind of standardized medicine that we would see in this country. They usually have English-speaking providers. And I've checked out IMAT clinics when I've traveled before, and I've always been impressed with the quality of care that people could get. So if somebody is sick when they're traveling and they're not real sure what's going on, there are some resources out there. Hotels, a little bit more challenging. Embassies, if you can contact an embassy, most embassies have a list of these are clinics that we consider people being seen at. They can't recommend a specific one, but they can at least give people a list of clinics to be seen at. So that's something to consider if you are sick during travel. And of course, if you come back home and you're not well, see your healthcare provider and have interesting conversations about fevers and diarrhea and why did that happen to me? So I will conclude there and open it up for questions if that's... Yes, sir.
It seemed like at one time it wasn't recommended that people my age get anything for yellow fever.
Yeah, so the other caveat for yellow fever, if you're 60 and older, you're more likely to die from the vaccine than you are to get the disease. So for people that are 60, and especially at 65, that even tilts a little bit more, because yellow fever is a live viral vaccine. And if somebody's immunocompromised and as we get older, our immune system doesn't work as well, there are people who actually get the disease from the vaccine. So for people that are over 60, 65, I really push the point on insect precautions. And there's actually on the World Health Organization vaccine card, there's a little section that we fill out and says this vaccine is contraindicated in this people. And then I'll actually give them a letter from the office saying, this person can't get this vaccine for this reason, don't give them the vaccine, don't give them the vaccine, have a nice day, So for people over 65, and really the risk of getting yellow fever in this day and age is pretty low with insect precautions, and then numbers have gotten smaller and smaller. And sometimes I actually do recommend, if it's high-risk individual, maybe not going on that trip. So that's another thing to consider also. But there are exemptions for people who can't get the vaccine for whatever reason.
So those are good when you enter a country that requires it.
Yeah, so if you got this yellow card, this is what they're always looking for. And I tell people, keep it with your passport, but if nobody asks to see it, don't show it to them. But there's a section on here that we fill out that says this person's exempt from the vaccine. Excuse me. And I've never seen anybody get hassled as long as they've got this and they got the backup letter. And the reality is, the vast majority of the time, people don't even ask to see this. On your trips, Michelle, do people ask to see when you go through South Africa?
Well, we haven't been to South Africa before, but with all the traveling we've done, I don't remember anybody ever asked.
Yeah, I've always got mine there because it would be the one thing they're looking for if you're going through customs or immigration. And I'm picking on South Africa because they seem to be kind of overboard and really emphasizing that people have this.
Dennis, Judy just said that when she went to South Africa last fall, she was asked to show it.
Going back and forth Victoria Falls and over to Botswana and all that.
Yeah, because you're going from an endemic area to a non-endemic area, and that's what they're supposed to be looking for. But it's surprising how often it's not asked for.
South Africa is going through a water shortage.
Yeah.
Water for washing. Is the hand sanitizer sufficient?
Yeah, so there's actually nothing better than soap and water, but the chemical gels, the chemical pads, the sheets that people wash with, they're equally effective for disinfecting our hands.
Would you comment about airplanes?
Yeah, they're kind of fun. So the airplanes are pressurized to about 7,000 feet for the most part. So people with underlying unstable cardiac conditions, they need to think about how less oxygen is there. Probably the thing that gets the most press with airplane travel is, oh my gosh, can you get tuberculosis on an airplane or do you get an infectious disease? And if you're in a crowded space and somebody's spreading viruses and they're coughing, sneezing, drooling, there's always that chance. I don't wear a mask myself, but I got some mask with me, and if the guy next to me is coughing, I might offer one to him if I can't change my seat. There was a case a fair number of years ago where somebody coming back from Europe was in steerage, the back of the plane, and had actually tuberculosis. And there was somebody in first class that came down with tuberculosis. And they're like, oh my God, the air is going from there to there. Well, the guy in first class was the buddy to the guy that was back in steerage, and he was going back and checking out all the time. So your risk of actually getting infectious diseases like tuberculosis are actually relatively low on an airplane.
What about wiping surfaces?
Yeah, I do take wipes to do the tray in front of me and the armrest in front of me because I guarantee you they don't wash in between. Probably the other important thing that you hear about with airplane travel is DVT, or blood clots to the leg. And for flights that are longer than 4 hours, there is I think a 1.2% risk of getting a blood clot If you have underlying conditions like varicose veins, previous clots, your risk is a little bit higher. And of course, they put us in seats now. Alaska Airlines has no padding at all. And they make room for the special people if the other people get crowded together, so you can't extend your legs out. So if you mobilize somebody in one place for a long time, you definitely increase their risk. If somebody's on a flight that's more than 8 hours long, the Swiss did another study. They're really good about doing studies, and they did ultrasounds on thousands of people that were on flights 8 hours long coming back from Africa, and 3% of people actually had clots in their legs. The vast majority of those people had no symptoms at all. That was the interesting thing about it, and they had no prior history of clots in the leg. So my take on that is, aspirin doesn't make any difference to reduce the risk of a clot in your leg. You have to be on different medications to do that. So I get an aisle seat, I walk the aisles every hour or two, I fidget a lot. Ask my partner, Ken, he'll tell you that. and part of that's just, I fidget a lot, but if you contract the muscles in your legs, you're pumping the blood, the veins, and you're a little bit less likely to get a clot. So getting up and walking and moving makes a difference. And then when you get to the airport for your next layover, if you go out for a walk, that makes a difference also. So just moving more to reduce your risk of a clot.
For noroviruses,
Yep,
any?
it's alive and well.
Yeah.
Hand washing.
Yeah.
Yeah.
But you see whole ships coming down and whole mobs of people. Is there any?
Well, actually, the cool thing about the ship industry, it's pluses and minuses, they've got like hazmat teams now. I mean, in the old days, somebody threw up or had an accident on the trip, it was just, they were vacuuming it, aerosolizing everything into the air. So anybody who walked through that cloud of germs just came down with it. Ships nowadays, I think, and it was presented at a conference in Seattle a few years ago, every surface that somebody touches, every 2 hours is washed down with a disinfectant. So they're not just polishing the handrails to make them look nice and shiny. More often than not, there's a disinfectant in that. If somebody has an accident on board, they throw up or whatever, I mean, they're on it in like minutes with their team, covering it up, putting a little dome over it, going in with their disinfectant solution, making sure it's dry before they open that area up again. Because ships, regardless of where they're going to, if they show up with an infectious organism on board, they'll be quarantined. And there are ships that have showed up in port that had to sit there for 3 to 5 days until everybody was screened to get off of that ship because they had a novel influenza virus or some unexplained high fever type of thing. So they're pretty good about trying to minimize that. And again, I've not been on a cruise, but people I've talked to, there are hand washing stations everywhere. That's what I'm hearing for people who do cruises. There's just every time you turn around, there's some place to wash your hands.
I was going to ask another question, but I have to comment that none of that is reassuring to me.
He said
But I wanted to see, I was really curiously impressed that you said that 1/4 of all the people who die on travel die in accidents.
Yes.
And I had an experience that I don't know how common it was, but it was really shocking to me. I was hit by a bicyclist in Friedrichshafen, Germany, on the bike trail. I was walking across it. I had no visibility. I was looking to my left, crossing ahead of me, and someone hit me from behind and never saw them coming, totally knocked me off my feet. The bicyclist went over the handlebars and landed next to me. It must have been going very quickly. I felt like I had a cross-body block. And I was knocked to my feet and cut my feet. I had Birkenstocks on. And
You were in Germany.
we were both, I think, in shock because the guy got up and he never apologized. And he got back on his bike and kind of stumbled away. And I just was kind of dazed for a while. And but it could have been so much worse.
Oh, sure.
I was by myself. And
Yeah, it speaks to safety and whatever you can do to try and minimize that. Was it a multi-use kind of walkway, or was it designated just for bicyclists?
well, it was a paved walkway, and I think it was generally a
Multi-use.
bicycle, but
Yeah.
that's.
I don't know if you guys learned this. I learned as a kid when I'm walking in traffic, I always walk towards the traffic coming at me. I don't want the cars and bicycles coming up behind me. And when I travel, I tend to do the same thing. My issue bicycling in Indonesia, we'd be on some remote roads and I'm going down the middle of the road, la, la, la. And suddenly a truck is coming at me, and I'm like, this side, that side, this side, that side. Usually it was just go for the ditch. You know, it's like I couldn't remember. Yeah, actually, people with venous insufficiency that wear compression stockings, that's one way to reduce their risk. But again, it's important to get up and walk around every couple hours also.
Quickly back to yellow fever. Is it your understanding that these countries that require it will accept a 15-year-old stamp on their...
Absolutely. It's taken 6 years, because this actually started about 6 years ago, that you only need one yellow fever vaccine in your life. So you had to go through all of the different state departments and Department of Health and get everybody on board, and that took a long time to do. But the conference I went to a year ago, everybody's supposed to be on board with that. But you do have to have, if you've got an old one that says it expired in 10 years, you do have to have a new one that says for the lifetime of the patient. You know, so I've had people get caught a couple of times thinking, well, yeah, it's good for a year, I just won't do it. But somebody has to give you a new yellow fever card that says for the lifetime of the patient for booster.
And who can give you that?
We give the yellow fever vaccine. I think there are a couple of pharmacies in town.
Well, I already had the vaccine
Oh.
12 years ago.
The card?
I have the card, but it's a 12-year-old stamp. I'm sure it says 10 years.
Yeah. So who do you see for your health care?
Catamount Clinic.
Yeah, so you talk to your healthcare provider there.
Just a normal guy can stamp it?
Yep.
Doesn't have to go to a specialist, just...
No, and actually most of them come through me because people's like, what do we do with this guy? I say, this is what we do with this guy, and stamp it and I sign it and give it back to you and have a nice day. Judy?
Yes, 2 questions. When you walk into the Catamount Clinic, you have an opportunity to pick up a mask. Is that the kind of mask that will work on an airplane, or does it have to be something fancier?
It's the kind of mask that I carry around with me. And if somebody's coughing, it's the kind of mask that I would offer them. It's not going to give me much protection, but what it does mostly is it catches some of the particulate matter when you cough and or sneeze.
So I carry them and I wear them when I hear someone coughing in my neighborhood,
Yeah.
and you're saying that's really not very
Probably
good.
not much protection.
Okay, and Promethean, you soak your clothes before you go, all the way
Yep.
down to your undies and so on, and
Well, if you're walking around in your undies and there's no pants over them, I would do my undies, but I probably wouldn't do my undies. No. There are other reasons not to do undies also, but that's too personal. Yeah, so yeah, what I would do, I would hang them up in the garage a day or two before, spray it down, follow directions on the container.
my question is, it says that it can be washed 4 or 5 times.
Yes.
Is that a gentle hand wash, and if you do a gentle hand wash, can it last longer? Because if you're on a month
Yeah.
trip to South Africa,
Yeah, so
You are
the stuff that we use to treat ourselves generally is considered good for a month, and 4 or 5 washings. And the ex officio folks are the ones that manufacture it pre-impregnated already, and their stuff was done just with a washing machine. So put it in the washing machine, put it in the dryer, a regular wash dry thing.
thank you.
But no softener.
Is that the case?
No, it's the sunscreen ones you mustn't use softener on.
Yeah. So actually, it's interesting you brought up sunscreen, because we travel to places where we get a lot of sun. Of course, we don't want to get skin cancer. If you're doing sunscreen and bug dope, you put on your sunscreen first, and then you put on your bug dope afterwards.
Have you heard of dryer sheets for insect repelling in an area where you don't want it on your skin, but you can have it attached to your hat or your...
I've not. It would be interesting to try that, put it on and set out on your deck and see what the effect may be.
Well, it has been pretty effective, and for people who are sensitive, that's what we've been using, and it makes an amazing aura, but people suggest that it might kill other things.
Yeah. Well, things like, the coils that people burn, it's a very, very narrow little area that they give protection in. So if you're really traveling to an area where you're dealing with diseases like high risk of malaria and whatnot, you really want to have something that will last you for several hours, and then that is going to work on your skin. And the picaridin, which is a plant-derived material, most people who can't tolerate DEET seem to do pretty well with the picaridin.
Yes.
So I was with a group, we stayed in a very nice compound it was in South Africa, and great louvered windows, absolutely no screens.
Yeah.
So I had a head net, and I ended up cutting up my head net and trying to tape it over the window and so on and so forth.
True ingenuity, I like it. Yeah. Yeah. Yeah, so whatever you can do to minimize bites, more power to you. Interesting thing with Africa, South Africa, there's only some of the game parks up in the northeast corner where you find malaria. The bulk of South Africa, you don't find malaria. But there are the other diseases, chikungunya fever, et cetera, that you want to minimize mosquitoes with. Actually, in Belize, it was interesting. I knew about insect-borne diseases there, and I did time in the jungle and the Keys and whatnot, and I didn't see very many mosquitoes, but I stayed at a homestay in Placencia for a few days, and actually I think the major breeding ground for the whole village was my shower stall. Because I'd walk into my shower, and there'd just be this cloud of mosquitoes in there because there was trapped moisture around the base all the time, and of course there were the little larvae guys kind of buzzing around there, and it's like, yikes, I'm gonna get malaria in my shower stall. It's hard to wear your clothing with permethrium in the shower. Andy?
I know 20 years ago you told me to get permethrin at the beats.
Yeah, so before some of the companies like Sawyer and 3M started giving us the pre-mixed permethrium in the spray bottles that we use, you could buy permethrium from the pet store because it's used for insecticides for sheep and other stuff. Permethrium, just a warning with it, is really toxic to cats' central nervous system, so never do permethrium on your cat. It does really bad things to their nerves. But yeah, I used to have a formula where you could put it in a Ziploc bag, add a gallon of water, mix it up, and then dip your clothes in or spray it. And actually, I think we actually even had a handwritten little sheet that we would give to people because it was very effective. And I don't know how this happened, but somehow it got to somebody in the federal system because we got a letter that like cease and desist on handing out because it's not intended for human use, even though the stuff that we use now is exactly the same stuff. But yeah, you could mix and match your own.
Years you could get it as Repel.
Yeah.
Repel made it. It appears recently, Fred Meyer's, it's now Coleman.
Okay.
Selling it.
For treating clothing.
It's not Repel anymore, yeah, it's sprayed aerosol.
Yeah, and permethrium is actually, it's not as much as a repellent as it is a insecticide. And when they land on it, they don't last very long at all. I mean, it's kind of it kills them off, but it kills them off before they can even feed through the clothing. It's that toxic to the nervous system of insects.
There used to be permethrin in a large yellow can.
Yeah.
Boo Hatch, is that it's 93%?
Yeah, actually you could buy it at Samson's Hardware.
Is it still available?
I haven't seen it in years.
Out of business, they closed down.
I haven't seen it in years. And again, it was intended to, I think Samson sold it to put on like furs, so if you trapped an animal and there were lots of critters in the fur, you sprinkled on. Yeah, wood ants, you'd sprinkle it around the perimeter of your house and the wood ant. I haven't seen the powdered permethrium in a long time.
Are there other travel specialist doctors or individuals?
Well, actually, it's a big part of my practice in family medicine, but most of my colleagues in family medicine do travel consults also. Kind of the cool thing with our clinic, if you walk into First Care and you got something really intriguing going on, we actually are a partner with Mayo Clinic, and we can access infectious disease specialist, mayoclinic.com, and say we have this interesting patient here with this history. There's also a network called the GS Sentinel Network where you can access it as a healthcare provider and put stuff in. The folks over on airport, I know we're doing some travel medicine for a while. I don't know if the folks that have the school district borough contract or not are doing it or not. So, and in pediatrics, we have Dr. John DePasquale, and he actually spent time with CDC. He did one of the South American Gorgas tropical medicine training courses. He's been a great adjunct to the clinic, and he and I get together and talk about interesting stuff all the time. And he actually, even though he's a pediatrician, he'll see adults also. So especially adults traveling with kids, John DePasquale and pediatrics at our clinic is a good resource. Well, I will thank you very much for your attention this evening.